Too early.
Hello everyone, my name is Goldberg Hanan. I'm a uro-oncologist here at MVHS, part of the Upstate Urology, and I have two distinguished guests with me as well, part of the faculty here at MVHS. I have Dr. Karna Sura, who is a physician at the director of the Radiation Oncology Department, and I also have Dr. Pinkhasov, Ruben, who is also a uro-oncologist here at Upstate Urology, part of MVHS, and we're holding this live Facebook Q&A event about prostate cancer. It is now Prostate Cancer Awareness Month, and I think we'll have some questions that I probably will start, and we'll hear the answers, and I think we'll take it from there, and I think it's going to be a very interesting discussion. So maybe we'll start with Dr. Sura. How prevalent do you think, do you know prostate cancer is? What is the data now?
Yeah, so the data in 2020 is that around 1 in 9 men will be affected with prostate cancer in their lifetime, and it looks like around 190,000 men will have prostate cancer, and around 33,000 people will die from it. And so usually prostate cancer across the board is like the #1 cause of cancer in men, but accounts for usually #2 for the cause of death in men.
Yeah, so it's a very common cancer,
Yes.
so men should be aware of this. And I have a lot of men asking me, what is the prostate? And maybe Dr. Pinkus, if you can shed some light, what is the prostate? What does it do? Where is it located?
Sure. So prostate is an organ that's found in the pelvis. In men specifically, prostate's predominantly responsible for production of prostatic fluid, which is very important for men in their fertile age, for spermatogens, not for spermatogens, for fertility reasons. Once you have your children and you're done, this organ essentially doesn't have any other function, and typically tends to grow predominantly driven by testosterone and dihydrotestosterone.
Okay, and can a man can live without a prostate? Is that something that we need to have, or?
Absolutely. So eunuchs, or people who are born without testicles, actually never develop their prostates completely, and they live a normal life, except the fact that they will have problems with having children. But once you go past a certain age and you have your children, there's essentially no need for this organ, and it essentially just becomes a headache for everybody because it can develop cancer. And as long as you're a man and you live long enough, chances are you will develop prostate cancer. This data has been shown in the past. But not every type of prostate cancer that develops is necessarily lethal and doesn't necessarily need to be treated. There are only certain types that can be lethal, and these are the ones that a urologist or radiation oncologist will be focusing on and treating.
Yes, okay, so we heard a little bit about how common this cancer is and what organ it involves or where this organ is located and its function. But what are the symptoms of prostate cancer? So Dr. Sura.
Yeah, so normally actually prostate cancer, the biggest problem with it is most people don't have any symptoms. I think that it's a very slow growing kind of insidious cancer, and so most of the time when people present, if they're going to present with symptoms, is usually bone pain or urinary symptoms when it's invaded into the bladder, or even rectal symptoms where with bowel movements, change in bowel habits. And so sometimes you get lucky and you have some symptoms with the increased frequency of urination, maybe some bleeding in the urine, some painful burning urination. So these are other symptoms that can kind of show, but they're usually not present in most patients who have prostate cancer.
That's true, and then typically the more advanced the cancer is, the more symptoms you may develop. So, in the early stages of prostate cancer, you will actually be completely asymptomatic. Once the cancer grows and becomes big, and it becomes an anatomical problem where you will have problems with obstruction, specifically, with getting urine outside of your bladder and peeing, so you may have some burning on urination, you may have weak stream and obstructive symptoms. The other possibility is if the prostate cancer is now more advanced and starts to invade into the rectum, you may start having blood in your stool and things like that, and problems with constipation and bowel movements. But these are the types of cancers that are actually very advanced, and because of screening and PSA and testing and rectal exams, we now detect these cancers at a much earlier stage. So a lot of times when they are detected, men are completely asymptomatic.
Yes, I think that's a very important point. As most cancers are really detected at the localized stage, and not when people are actually, as Dr. Sura, Dr. Pinkhasov alluded to, that people are actually asymptomatic completely. Are there any risk factors, anything that we know that can cause prostate cancer, Dr. Pinkhasov?
Yes. So we don't actually know exactly what causes prostate cancer. We used to think, in the past, that prostate cancer was driven predominantly by testosterone and by dihydrotestosterone. But this has sort of been in flux and in question whether it really is a direct cause and effect. There is some correlation, but there is no direct cause and effect to that age. There are, however, very identifiable risk factors that have been known for a while now. So if you have any family history of prostate cancer, if you have any family history of breast cancer in both women and men, if you have any history of ovarian cancer, or any type of metastatic adenocarcinoma like pancreatic cancer, these are risk factors for developing prostate cancer. The other thing is men of African American descent are at a higher risk of developing prostate cancer. So if you are of that descent, then you should be sort of more stringent and seek help earlier and be more cognizant of that. And the last factor is age. The older you are, the higher the likelihood or the chance that you can develop prostate cancer.
And what age usually do you see prostate cancer? What's the average age or the median age?
Yeah, so we typically start screening men at the age of 50 to 55, and the guidelines on that are also variable depending on which ones you look at. What we don't recommend is screening any man for prostate cancer less than age of 30, because the risk of having prostate cancer at this age is extremely low. It's almost negligible. For people who are in the age group of 40 to 55, we don't routinely screen these men for prostate cancer. But if you have any type of risk factors, which is family history, being of African American descent, family history of breast, ovarian, or pancreatic cancers, then these are the people that will benefit from screening in this age group. The most benefit in screening for prostate cancer happens to be in the population between the ages of 55 to 69. Some people actually widen this gap and include from 50 to 75. This is where the studies show that if you screen these men, then detecting prostate cancer is more reasonable in this age group. The guidelines also do not recommend screening for men for prostate cancer over the age of 75, or if they have less than 10 years of life left. And the reason for that is very, very clear, because prostate cancer in general tends to be a very slow and indolent type of cancer, which takes a long time to progress. So the thinking behind this is if you're in your 70s and 75 or older, or if you have less than 10 years of life left, chances are you probably will outlive this cancer, and so therefore you don't need to be as stringent in diagnosing it and treating it.
So you're saying that if you're very old or your life expectancy is quite low,
Yes.
there's probably no role in prostate cancer screening at this point.
Exactly, because you probably will outlive it, or something else will get you before prostate
That's
cancer.
a very important point. And Dr. Sura, on the same note, is there any way you can prevent prostate cancer?
Yeah, I think like with any type of cancer, the most important is exercise, weight loss. Those are pretty basic things that you can do to prevent any type of cancer. As it is testosterone generated, we know that people with larger body habitus have more testosterone available. Other thing is vitamin D supplementation. Some people think will help with the trying to prevent it, and then also stopping smoking. There are other things that you can do medically, but usually that requires a doctor's visit and have a family history of prostate cancer. So those are the basic ways. There are other medications that have some benefit to them, but usually you want to take a more informed discussion with your physicians about that.
Do you want to add something?
Yeah, so this is my sort of area of interest in terms of what actually prevents prostate cancer, and I find it fascinating that there are certain diets that actually reduce your risk of developing prostate cancer. Specifically, what I'm talking about is a plant-based whole food type of diet, and it's been studied, and it actually has been reported that the rate of reduction in prostate cancer actually decreases by at least 30%. So there are some, but this is of course based on some retrospective data, and there are prospective studies that are being undergoing. But there's also a few clinical trials that have been done in this area, specifically the SELECT trial, which looked at things like selenium. It looked like and other vitamins and supplements to see if taking those reduced the risk of prostate cancer. It turns out that essentially neither selenium, no vitamin E, no other supplements that they studied in this study specifically actually showed any improvement in reducing prostate cancer. But the caveat to all of this, though, is you have to also understand that even if prostate cancer does happen, it takes a long time for it to progress. And so even though the study that was done over a certain period of time may not necessarily show a benefit, doesn't necessarily mean that it may not exist there. Maybe they needed to study this for longer. We don't know. What we do know is regular diet, regular exercise, and plant-based whole foods types of diet will reduce your risk of prostate cancer. And there are certain medications that are possible, but again, these are still being studied and investigated.
Yes, I think it's very important. I think that the known things, as you both said, is the exercise, stopping smoking. These are things that have been shown. I think all the studies that you mentioned, selenium, they're all negative at the end of the day.
Yes.
There are many drugs that are being assessed, like statins, metformin, which do seem to have some kind of role in prostate cancer prevention, but I think there's no prospective data yet.
Yes.
So we cannot recommend this yet, but I think in the next few years we'll probably have more data on this. So basically, how do you diagnose prostate cancer, Dr. Sura?
Yeah, so mostly prostate cancer is done by during your annual physical with a DRE and a PSA test. The PSA test is a prostate-specific antigen. It's a blood test that you get, and the DRE is a digital rectal exam. So basically, with the exam, you can feel the prostate and see if there's any abnormalities, meaning any nodules or any issues with the prostate that you think could help with that. The combination of both of them are very effective to finding prostate cancer.
And who does this test? Any doctor or?
Usually your primary care does it. Sometimes if you have a urologic problem, you may see a urologist who also does it. So those two components kind of help to guide to say that you may need more workup or more consideration from that.
Okay. And you talked about PSA, and we all know PSA is although it has its advantages, it is also very problematic, right? Dr. Pinkhasov,
Yes.
Expand on that a little bit.
Yes. So a PSA it stands for prostate specific antigen, but I actually like to call it patient specific anxiety marker. And the reason is because a patient comes to me and he says, "Oh, my doctor told me that my PSA is high; it's above 4." Now, the truth is this: there is actually no normal value for a PSA, because you can have prostate cancer and have a PSA that's low, that will be below 4. The cutoff of 4 was actually sort of determined and published in a very famous article back in 1992 in New England Journal of Medicine, where they actually showed that if you have a PSA of 4 or higher, your risk of prostate cancer increases by at least 25%. So then everybody jumped on this cutoff value and they're using this. But the truth is, there's a lot of people that will be around that will have a PSA of 3 or PSA of 2.5 or 2.75 and will still harbor some cancer in them. And then there's also PSAs that will be in their 15s and 20s, which may not necessarily have prostate cancer. So the marker itself is not a reliable diagnostic tool. It's an excellent marker to monitor cancer once it's been treated, but it's not a perfect screening tool. And so there's other surrogates that we use to add. Specifically, rectal exam can contribute. There's also a variety of biomarkers that have been developed and established, including the 4K and the MDX and the select MD and all of these other biomarkers that were recently published, and PHI and all these other factors. But one thing I should clarify to patients and let them know that is it's not a one-size-fits-all kind of thing, and it's not necessarily that one marker is better than the other, and selecting a group of people that will benefit from this type of marker is also very important. So it's not that every single patient should get, let's say a 4K score, because not everybody will have an abnormality there. It's very patient-specific and individualistic. There's also a variety of new imaging techniques that have been developed. Specifically, the 3 Tesla MRIs can be more informative than just doing a biopsy without one of these imaging modalities. So it's there's a lot of new promising markers that are available, but you need to know how to wisely use them so that you just don't order these and don't know how to interpret them.
And maybe you can expand a bit, because PSA is also rising and other things can cause PSA to rise.
That's correct. So prostate specific antigen is not very specific to the prostate. What I mean by that is there are other organs that produce PSA. Specifically, our salivary glands produce PSA. Our pancreas produces a little bit of PSA. These numbers are negligible or very, very low compared to what the prostate produces. But once in a while, we'll see a man who will have, let's say, a salivary gland tumor, which will now start to produce a lot of PSA. And it's not because there's a concurrent prostate cancer, it's just, it might be because of the salivary tumor. And once that salivary gland is removed, the PSA normalizes. So just be cognizant that PSA is not necessarily just produced by the prostate. There are other sources of it.
And Dr. Sura, PSA, even from the prostate itself, can be high because of not prostate cancer, only other reasons like prostatitis.
Yeah, so like an infection of the prostate is a very common example of that. And usually before we even go down the prostate cancer road, we usually try to give them antibiotics and see that, because it's very hard to usually diagnose an infection of the prostate, but it's a very common reason for PSA to be elevated. So that's usually the first way we try to make sure it's kind of, sometimes prostate cancer is a rule-out diagnosis more than a rule-in diagnosis.
So that's very true. So inflammation of the prostate, any prostatic stones, if you have sex within 3 days of the PSA test, if there's any type of a catheterization, all of these things will sort of traumatize the prostate a little bit and cause spillage of this PSA, which will artificially be elevated in your serum. So, the first thing that any man that comes to my office is with an elevated PSA is I repeat the PSA and confirm that indeed it is elevated before we start any type of diagnostic workup. And that's because, there's so many variables that are involved in this marker.
And I think just to summarize a point you said, because a lot of men do have PSA tests and they're very scared because they have the first test and it's suddenly very high, and it's not necessarily means that it's cancer, right? Because it might be a whole lot of other things.
Correct.
And I usually, I don't know what you guys do, I imagine you do the same. I usually repeat the test always to make sure.
The same thing with me.
Yes, to make sure that it's real. But again, when they do have this PSA, I think it's very important, as you said, Dr. Sura, to examine them also and have the rectal examination and have them see a urologist at the beginning, first of all, to see what the cause of this.
Well, I think the PSA, the other important thing about the PSA is that it's not one exam that we base everything on. It's actually multiple exams. And even in pre-treatment and post-treatment, that's the most important, is that this is a reflection of you at one time, but we want to see the whole kind of pathway.
Yeah.
And so that makes a huge difference, especially we may check it multiple times before we actually proceed with something, because we don't want it to make we want to make a better informed decision. And actually time tells a lot with, as prostate cancer is a very slow cancer, you can tell a lot more with multiple, lab tests.
Yes. Okay. And now to the men listening to us, and the 45-year-old man, the 65, who should get tested, and when should get tested? What do you recommend?
Yeah, I think the most important for these men is that usually, like Dr. Pinkhasov said, that age 50 is a good example of somewhere that you can consider it, but you have to have a good discussion with your primary care provider about the pros and cons of, and understanding, what are the risks and benefits. And I think that's one of the things that is in the guidelines that talk about, if we go down the PSA road, that there may be, it may be positive for other reasons, not besides prostate cancer. And so usually for most men who don't have any high risk factors, our average risk, usually 50 is a good age. Now, if you do have a prostate cancer history, I think that you definitely need to get screened earlier and get checked, especially with family with breast cancer or prostate cancer, something that makes you more high risk. These men are definitely need to get checked beforehand.
And Dr. Pinkhasov, if there is men listening to us, if they want to have prostate cancer, being screened for, being tested for them, what should they be doing? What's the first step that should they make an appointment with a urologist? Should they see their primary care physician?
First thing is, if you're worried and concerned about prostate cancer, see your primary care doctor, because they will basically figure out and screen you and determine whether you need to have a PSA test or not. And then if the PSA test comes back concerning or elevated, or the rectal exam is suspicious, then the primary care doctor usually will refer out the patient to a urologist or a radiation oncologist. And depending on what else needs to be done, it's essentially then in the hands of the urologist to complete the workup, or the radiation oncologist to complete the workup before the treatment is begun.
Yes, I agree completely. So if you have been diagnosed with prostate cancer, what are basically the treatment options? And I know this is a growing field today, a lot of options, so can you maybe summarize this for us?
Yeah, so the first step is staging you. So whenever someone's diagnosed with prostate cancer, the first thing we do is order a lot of imaging to kind of make sure that the cancer is still to the prostate and hasn't gone to the lymph nodes, haven't gone to the bones. And so that's our biggest, the first step of kind of everything. But most men are luckily found as a localized prostate cancer, especially with PSA screening. And so with those localized prostate cancer, you can get surgery. Some men may not need any treatment. They can actually enter what we call active surveillance, where we're checking the PSAs regularly, potentially doing biopsies every 1 to 2 years, and really checking the prostate, and they may not need treatment. Other options include surgery, which is Dr. Pinkhasov's specialty, and then radiation, which is my specialty. And they all can vary in that regard.
So what are the differences? Maybe Dr. Pinkhasov, you can share. Who gets radiation? Who gets surgery? Which is better for which?
Yeah. So this is the whole.
We're going to go controversial area.
No, it's not that. It's just this is sort of very individualized and individualistic type of thing, because it depends. It depends on what your goals are and what you want to get out of this. And I tell this to every patient that I treat. My goal is not to tell you what to do and what my goal is actually to figure out what your goals in this care are, and my job is essentially to figure out how best to get you there. And the reason this is such a sort of a controversial topic is, if you speak to a radiation oncologist, they think that everybody should get radiated. If you speak to a urologist, they will think that you should be headed into surgery. But the truth of the matter is, if you look online on the internet, there's millions of treatments for prostate cancer. There's things like freezing the gland, there's things like microwaving the gland, there's things like using electroporation, which
is
is
focal therapy.
For focal therapy, yes. There's also things like chemotherapy that are available. There's androgen deprivation therapy that's available. But the truth is, for localized prostate cancer that's confined to the prostate, there's only 2 types of treatment in the United States that are considered standard of care. And that includes surgery and radiation. Now, whether you need surgery or radiation will depend on a lot of factors and a lot of things, and what your goals are in terms of how you want to get treated. If you compare the data in terms of survival of how many men live after they have surgery versus how many men live after they have radiation, and you look at the 10 years survival outcomes, and you compare the two treatments, it turns out that the same number of men who actually had radiation live to the same number of men who had surgery. So the two are equivalent at 10-year mark. If you look at the data at 15 years, they're exactly equivalent as well. If you look at the data at 20 years, the two are actually approaching equivalence as well. But I do have to add one caveat to that. Radiation, the way it's delivered now, is different than what it was 20 years ago. And so even though the data is showing that they're approaching equivalence, and it probably is equivalent, we don't have as much data on radiation for the same way that it's actually been delivered. And correct me if I'm because it has changed, and surgery has changed as well. We've been doing surgery for over 100 years. We used to do them open. Now about 80% of the country is doing this type of operation with the robot.
So what does that mean? Does the robot do the surgery?
No, that's actually the most common question that I get asked by patients. It's not as if you go into the room, press play, and look out. That's not how it works. The surgeon always is in control of the robot. The advantage to robotic surgery is that we make smaller incisions and we use our hand gestures, but the surgeon is constant control of the robot. It doesn't do the surgery by itself. It doesn't do any of the, it's essentially is fully controlled by the surgeon. The reason why it's advantageous to do this robotically is you have better pain control. The discharge rates or patients leave the hospital quicker, they recover faster, they recover quicker, because the machine actually allows you to be in certain areas of the pelvis, which is very deep down there, and has much higher magnification, allows you to see things more clearly and dissect tissues and develop planes much more easier than it would have been if we were doing this in open fashion. And so it's a little more precise, it's more magnified, but it also is heavily dependent on surgeon's experience, because I will tell you, I've seen both open surgeries and I've trained in both open and robotic surgery, and there are some surgeons who are exceptional open surgeons. They may not necessarily have as well pain control and recovery as a robotic surgeon, but there are also some exceptional robotic surgeons, and there's also a mixture of both who are not as good open surgeons and not as good robotic surgeon. And the treatment decision of which one is better, it really depends on surgeon's experience and comfort. If they're very well trained in robotic surgery, don't ask your surgeon to do an open surgery. If they're very experienced in open surgery, don't ask them to do robotic surgery, because they will be struggling with those techniques.
I think the important point is that so far, at least the data that we have, they did not show any difference between the outcomes between open and robotic surgery.
Yes.
Maybe the recovery is a little bit faster,
yes,
but the outcomes are eventually the same.
Correct.
And do you want to maybe elaborate on the radiation, how it's changed through the years?
Yeah, so radiation, the one thing I want to reiterate is that there's no really difference, because that's the first question that people walk in and ask, what's the difference between surgery and radiation? And there's no difference between the outcomes, they're the same. And so it's really the side effects that you're willing to accept that's the most important thing. And that's what I tell all the patients, is that it's not, you got to accept what side effect that you may get down the road, and that's what really is the most important part.
And there's external radiation, right? There's brachytherapy. Do you want to elaborate a little bit?
Yeah, so with external beam radiation and brachytherapy, so there's different types of radiation, external radiation and then internal radiation. Both are very effective modalities of radiation. And from previous to now, what we've learned is that the prostate gland is prostate cancer is very stubborn. And so we used to not treat it to a high dose. Now with new technology, meaning we can check the prostate every day, we look at the volume, we can do higher doses, we have better technology. And so all that allows us to do higher doses of prostate to really get rid of the cancer. And we found that the higher doses is actually more important and prevents the prostate cancer from coming back. And so that's really a big technique difference between prior to now.
And how long do you need to get the radiation for?
So it varies now. I think that there's, normally we used to do 9 weeks of treatment for external beam radiation, but some men we can do 5.5 weeks of treatment, even less than that. Some people can benefit from even 2 weeks of treatment or 5 treatments, and they're done. But this is individualized to each patient, and so that's the most important part of it, is that it's not one size fits all, and unfortunately it's all based on what your characteristics are. With brachytherapy, you can even treat it in one treatment, where we put the seeds in, and people like that. It's more like a hybrid surgical approach with radiation. So all these are great options for patients.
And you mentioned a little bit about the side effects. Maybe Dr. Pinkhasov, you want to speak? What are the specific, maybe of the surgical standpoint, the specific side effects of the procedure?
Yes, sure. So there's what I call short-term side effects, and then there's long-term side effects. They're actually for surgery. So specifically, short-term side effects include things like having blood in your urine, after the procedure, and then all these, frequency, urgency, having anesthesia-related side effects like developing blood clots in your legs, maybe one of those clots migrating and going to your lungs, causing pulmonary embolism and things like that. These are all essentially very transient side effects, and they're resolved within a few weeks. The long-term side effects are the ones that what I call the 3 I's, which is incontinence, infertility, and impotence. Infertility means that after this procedure, after radical prostatectomy, or if you have radiation therapy, you won't be able to father any more children. Impotence means essentially not being able to have good quality erections right after surgery. And the truth is, the quality of erections goes down, and then over time, if you had nerve spared, you may regain most of it, and close to 90% of people actually are able to regain 90% of their erections back. The last one is incontinence, which tends to be the most bothersome to men. And that's the one that, what it means is basically you'll be leaking urine. Now, right after surgery, everybody leaks urine, and over time, as time passes by, you regain your ability to control urine, and this partly happens because your sphincter muscles that are responsible for continence are essentially basically go into a shock, and then they recover slowly. And on average, it takes anywhere from 6 weeks to about 6 months to regain. Some people go up to a year, and then older men tend to go up to 2 years before they'll regain their ability to control urine. But close to 90% of men actually are able to regain at least some form of control, to the point where they may be only using one pad for security reasons. If they cough or sneeze, they may leak 1 or 2 drops. But majority of these, very rarely do we see, or I should say about around 10% of men we see that will have full incontinence, which means that they can't control their urine, and they're using at least 3 or 4 pads or more. What's your experience, Dr. Goldberg?
Yeah, I completely agree with you. I think you said it correctly, and that's the percentages. Maybe you would like to elaborate a little bit on the radiation?
Yeah, so the radiation is a little bit different. So we have some risk of incontinence, but it's a lot lower, usually around 1 to 3%. Erections are a big issue with radiation. Usually, unfortunately, we affect the blood vessels down there, and so usually with the blood vessels, you may have a change in your erections. Around 30 to 40% of men have a quality of life change where they can actually feel or have a change in that. The biggest one that's different from surgery is the rectal side effects. A lot of people have some rectal bother, and the dreaded side effect is like a rectal ulcer from the radiation. Again, very unlikely for that to happen, but it's very, when we look at quality of life data, that's the biggest issue, is probably more urinary side effects for the surgery and then more rectal side effects for the radiation.
So just summarizing a little bit, so we have basically 2 big definitive options for treatment: is surgery and radiation. And we did not mention sometimes radiation needs to be given with hormonal therapy as well for more high-risk disease. There's active surveillance, which is a protocol. Maybe Dr. Pinkhasov, you can just do a little bit of order. Who's the right patient in your mind for radiation? Who's the right patient for surgery? Who's the right patient for active surveillance? Just so people get a sense of.
Yes. So like I said before, it's not one size fits all. It's very individualized to patient. There are some general guidelines that we like to follow because of the side effects that are associated with these. So men who have low risk or very low risk prostate cancer, they essentially are put on active surveillance.
Which means actually maybe.
Which means we don't treat you immediately. We basically delay your treatment, and the truth is about 2/3 of men who get on active surveillance stay on active surveillance for the rest of their life and never require any treatment. Only about 1/3 of men will have disease progression, which will require intervention or sort of treatment. Now, the reason why this is sort of very important is because not every type of prostate cancer is lethal. As I started, in the beginning, as I mentioned this in the beginning, 97% of men will have a type of cancer of the prostate that may actually not necessarily affect them in their lifetime. About 3% of them will have a lethal type, and that's the one that the radiation oncologists and urologists focus on. But so people who qualify for active surveillance typically will get on it, will have a rigorous and stringent monitoring of the PSA and rectal exams and maybe additional imaging tests with MRIs, but they do not necessarily get converted to treatment unless there's something concerning, where their PSA is rising, the rectal exam changes, or there's a Gleason grade progression. What I mean by that is the pathology was initially, let's say, a lower risk type of cancer, but now became a higher risk on additional biopsies that are done, when you're on this program. So active surveillance is a big chunk and part of our practice, at least in my practice. I'm sure it probably is in yours. But those are the people that about 2/3 of them, as I said, will never require any type of treatment. And then the people who are usually younger, what I mean by that is in their 50s or less than 60 years of age, we tend to steer these people more towards surgery. And the reason is because they're very young, and with the difference between the radiation and surgery in terms of side effects is the onset of the side effects. With surgery, they happen immediately, and over time, things just get better in terms of recovery. With radiation, it's the opposite. They'll get radiated, they'll be completely fine. They won't have any symptoms, they won't have any problems until a few years later, where they'll start having, things like impotence, things like incontinence, and things like that. So if you think about it, if you want to treat a man and give him the best benefit of the doubt in terms of survival outcome, the two treatments are equivalent. But if you want to delay their side effects, then what you want to do is offer more radiation to older men over the age of 70, because by the time these side effects kick in, they will actually outlive it. And so they may not necessarily even get those side effects, but they'll be fully treated for this disease. Younger men, we prefer to actually do surgery on them, because they will actually live at least 20 to 30 years, and they are the ones that are going to be stuck with these side effects. And you want, if you radiate them, these side effects will just get progressively worse and worse. And with surgery, they actually will get better and better. And so younger people, we steer more towards surgery. Older people, we steer more towards radiation. And then the age group of 60 to 70, they have an option of either or, because these are the people that will benefit from either type of a treatment in terms of survival outcome, and also in terms of minimizing the side effects. But again, this is not in hard stone, and this is not a hard rule. There are variations, and it's very, very individualistic. There's a lot of parameters that are coming into consideration, specifically what their erectile function status is, what their current continence rate is, what type of cancer they have. And some people will actually need both surgery and radiation, especially if they have a very high risk type of and very aggressive type of cancer. So it's not just one size fits all or age criteria. It's very individualistic and depends on what your pathology is and what you present with.
I think it's a very important point. I think the good thing here about MVHS is that we work very closely together, and I think every patient that we see gets seen either both by a uro-oncologist and radiation oncology,
yes.
and eventually the patient, together with both physicians, choose what kind of treatment he wants to do. I think
Yeah,
that's right. That's right.
That's a very good thing here.
The other thing is, this is actually a very important point, and the reason why I emphasize this is when you come to a cancer center like this one, you essentially get seen by a urologist, you'll be seen by a radiation oncologist. If you need to see a medical oncologist, you'll be referred to medical oncologists, because this is a multidisciplinary approach. And it's not that we feel that you may need radiation and not necessarily surgery, or if you need surgery and not necessarily radiation. It's just the more patients know about this disease, the more informed they are, and the better they can make these decisions on what's best for them.
And I reiterate that it's important to have both opinions, because I think
Correct.
that you get both sides of the story, and the patient has a better view. Not only that, but they actually understand about their disease more. It's very
Exactly.
hard in this time. A lot of people have a lot of anxiety
Correct.
and confusion about what's happening, and this allows them to answer more questions and really get used to everything and actually know what that's happening. And getting more information is better than having little information. And really, it's the whole point of this is the patient gets to decide. We don't tell you which one's better. I think that from our experience and working together is that's a joint effort to have patients
Right.
learn everything.
Yeah. And before we move to the last question, any thoughts about focal therapy? Do you want to say, both of you, maybe is there a role? Is it good for patients, Dr. Pinkhasov? Do you?
So I will tell you, there are certain patients that will benefit from focal therapy, but it's a very select type of patients. Focal therapy, of course, as you probably all know, is still in its infancy, and is still being developed and still being studied, and not every single patient qualifies for them. I will certainly tell you, people who have lower risk prostate cancer, they tend to do well with these types of therapies. Also, people who have quite significant comorbidities and had treatment before for prostate cancer, like radiation, then they may actually benefit if they have a focus of cancer that recurred. So there are certain criteria, but my experience with this is I have actually a very limited number of patients that required focal therapy. Not because I don't believe in the technology, I think it's great, but I think it needs to mature a little more before we actually introduce it into practice. And they're not necessarily a standard of care yet. They will probably be at some point once all the studies are completed and the benefits are fleshed out. But at this point, they're still sort of in its development stage. What are your
Yeah, I
thoughts
think
on-
focal therapy, the biggest problem with it is in the primary setting, we have two very, very good options, and it's very hard to beat them. And so right now, and we know from biopsies and when we do all these, the prostate usually have cancer not in one location, it's
Yes.
usually a lot more places than we expect, and sometimes when we don't expect. And so these focal therapies unfortunately don't affect the whole gland. And so when you have such a good option up front, usually we use focal therapy as if it comes back locally or as a second line therapy to really kind of decrease the risk of more toxicity, but really kill the cancer. And so, in my experience, it's just a very small percentage of patients that really benefit or need it. It is definitely an option, especially radiation. We could definitely hit it, but the problem is the studies haven't shown that there's a benefit, and it will take some time before we actually see that.
Yeah, I completely agree. I think it will be probably an option someday for patients in the future, especially the patients with more comorbidities. But I think that, as Dr. Pinkhasov said, the research is still not robust enough. And I think we need to await the results of the studies to see if this is an option, because this will be a very sexy option. Patients will be interested in this because it has potentially less side effects. So it will be probably a valid option one day. So what is the prognosis? A lot of patients ask, what is the prognosis of a prostate cancer patient? How long can you live with prostate cancer, Dr. Pinkhasov?
So I think it depends on what you're starting with. I will tell you, in the past, we used to treat Gleason 6 prostate cancer, which is essentially not a very aggressive type of cancer, and we used to pride ourselves and pat ourselves on the back that we cured this patient. The truth is, now with the information that we have, And with the active surveillance data that we have available, most of these patients with low risk and very low risk prostate cancer probably didn't need to be treated to begin with. And so the prognosis for these patients is actually very, very good, whether they're treated or not. And we now advocate for less treatment and more active surveillance for these patients. So the prognosis for them is very good. The other spectrum, the other end of the spectrum is people who have very high risk prostate cancer and very aggressive form of cancer. These can actually progress quite a bit. But as I told you right from the beginning, overall, prostate cancer, even in its most aggressive forms, it's not like pancreatic cancer where you will get diagnosed and you have 6 to 9 months left to live. Prostate cancer takes a long time to blossom out. And my mentor, where I trained, used to say this to his patients. He used to say, if there's any type of cancer that I would choose, God forbid, of course, but I would choose prostate cancer because it is a very slow-growing type of cancer, and we have a lot of treatment options that are available. And more importantly, there are newer agents now that are coming out on the market that will essentially suppress this type of cancer, even in its metastatic stage, and can prolong life for quite a bit of time. So the prognosis is actually very individualized. For low risk, it's very good. For high risk, it's not as good, but it's still very treatable type of a disease. I mean, not necessarily curable, but it is treatable. And like I said, we were talking on the order of 4 to 8 years, sometimes to 12 years. Data shows that people with who have metastatic disease can live up to 12 to 15 years. So it's with the agents that we have now that are available. So it is very sort of indolent and slow-growing type of cancer. It's not like pancreatic cancer, like I said, that will kill you in 6 months.
You want to add something?
Yeah, I mean, there's so many agents now in the market that it's crazy when we put some of these numbers in, and the likelihood of even people with metastatic disease dying from their prostate cancer is very low. I mean, it's surprising, even shocking when you actually calculate people's odds. And the reason is we have so many good agents on the market that actually work very effectively and kind of can freeze or actually even get rid of the prostate cancer. And so I think it's really important that even in that spectrum that you have aggressive therapy, and we know that aggressive therapy improves outcomes and really keeps people living, potentially even with metastatic disease. If you have limited metastatic burden, you can even cure their cancer. So it's really, it's actually a very big area, and the number of drugs on the market for prostate cancer is astounding, and how many options there are. So.
Yes, I agree completely. I think it wasn't always the case, but in the last decade, I think there's been a plethora of data on new agents coming out. And as you mentioned, there's so many treatment options today, chemotherapy and androgen receptor antagonists, and lots of treatment options. So even if you do have advanced disease, it does not mean automatic death. Of course, the always the goal of the screening, I think, Bill, is to find those high-risk patients that we're looking for, that their disease is progressing very fast and in a very scary manner, and those are the patients we want to diagnose. But it's important to be screened. That's the only way that you can know. Any take-home messages before we conclude this, Dr. Pinkhasov? Any recommendations for patients?
Yes. So if you're a man between the age of 55 and 69 and have never been tested for prostate cancer, go ahead and get screened for prostate cancer. Of course, as I said before, if you're in your 30s or less than 40 years of age, you don't need to be worried about this as yet. And in the age group of 40 to 55, if you fall into that category, unless you have family history of prostate cancer or you are of African American descent, speak to your provider if you do need to be tested or not. It depends on your risk factor status. And of course, my last recommendation is if you have less than a lot of comorbidities, or if you're over the age of 75 or have less than 10 to 15 years of life, then you probably don't need to be screened for prostate cancer, because it's not going to affect you in your lifetime. So why worry about it? Why create unnecessary anxiety and diagnosis, and be concerned about it if you don't need to be treated, or if you're not going to be treated anyways.
Dr. Sura?
Yeah, and if you are diagnosed with prostate cancer, I mean, I think that it would be nice, or we have a great team here that we work together and have an ability to treat you in a very in the most state-of-the-art ability and facility. That we have all the technology, anything that from radiation, from surgery, we do everything that's modern. So, and you'll be treated by a whole team. It's not just one person that's dictating your whole care. So, it's a very good atmosphere, and if you want, we can always see you and give you an opinion about radiation or surgery or anything.
And one other thing that I want to point out and emphasize that a lot of private practices in the area cannot offer is we have this multidisciplinary approach to cancer care. So if you get diagnosed with certain type of cancer, especially if it's an aggressive form of cancer, we have this meeting that we hold quite often, and we discuss complex cancer patients. So in the room you have a radiation oncologist, you have a urologist, you have a pathologist, you have a radiologist, you have medical oncologist, and we're all essentially a team where we try to figure out what's best, what type of care can be offered to this patient and what's the best treatment option. And ultimately we'll go back and forth arguing on what the new studies show and what new trials showed and things like that. It's a very sort of productive and collaborative effort. And then at the end of the day, we'll boil down the treatment options to a few choices, and these are the choices that are being then presented to the patient to select, and explain to them, here's what the group thought, this is what you have, these are your treatment options. We felt that we probably would recommend this, but it's really your choice, and it's sort of a very collaborative type of effort. And I'm actually very proud of this, because Dr. Goldberg started this program here and built it from ground up.
Yes, thank you very much. So I think that the points raised by Dr. Pinkhasov and Dr. Sura are very important. I would add that for take-home messages for men listening and watching us right now is go get screened. That's the most important thing you can do, especially if you're above the age of 50 or 55, especially if you have risk factors, if you have family history, if your father or brother or uncle had prostate cancer, and all the risk factors that we mentioned before. I think it's the most important thing to go, first of all, to your primary care provider, get a PSA test, and probably be seen by a urologist after that, and we'll guide you through that journey from that point. And if you are diagnosed with prostate cancer, I think it's, as Dr. Pinkhasov and Dr. Sura said, you need to come to a center such as MVHS where there is a multidisciplinary approach, where you can be seen by more than one doctor. You can be seen by radiation oncology, you can see by a uro-oncologist who was specifically trained in oncology. You can be seen by medical oncology, and you offer the whole multidisciplinary approach for treatment. I think that's most important. And a lot of centers have this, but this is still not prevalent everywhere, and I think it's important to go and be diagnosed and treated at such a center. I want to thank Dr. Pinkhasov and Dr. Sura for joining us and for your valuable opinions. I want to thank MVHS for hosting us and doing this event.